Reno Sparks Indian Colony dental program in 1999, and we realized that there was nowhere to send children or special care adults who needed care in a hospital setting. So the Indian Health Service assisted me in setting that up in Northern Nevada. I think we must have done about a couple of hundred children before the time I retired. But then I was recruited by St. Mary's Hospital to set up a program for them. Since that time, unfortunately, I provided about 10,200 of these cases in the hospital. So I'm hoping Jeanette's got my PowerPoint up that you can see.
Yep. I will go ahead and start sharing that. I just wanted to let everybody know that I am recording this meeting and this presentation. So let me go ahead and pull that up. And you just let me know when to switch the slide.
Thanks, Jeanette. All these pictures were taken by me at the time of our move from the St. Mary's Hospital program to become part of Community Health Alliance when St. Mary's was absorbed or merged. And these are some of the places that we provided care initially. You probably noticed that there are only one or two available in the whole state now that provide hospital dental care. Next slides, please. Thanks. These were all the original places that I provided care to patients on the hospital setting. And, you know, in public health, like all the people sitting on this meeting, we think about providing care. We don't usually think about money. At least I didn't. It was all about getting care to our patients. Next slide, please. But unfortunately, there's a lot involved here. And just to build an operating room, it costs approximately $1.4 million. So obviously, the surgical center or the hospital has to get something back in order to support this. Next, please. This whole process starts off about a month or so before the child even gets to the hospital. You'll see the child or the special care adult in your office or your clinic and determine that you can't take care of them in an outpatient dental setting. So you'll start making arrangements, and one of your staff members will have to arrange for a history and physical for the child so that you can make sure that they'll be well and be able to get through the program. Then they arrive at the surgical center or the hospital, and there's a preoperative phase where the nurse and the anesthesiologist will examine the child, go over their history, and then everybody needs to get a consent. Next, please. As you all know from the people you deal with, you know, the majority of the people that we see, or the children and special care adults that we see in this program, are mostly Medicaid, or the vast majority are Medicaid. And that's why you asked me to talk. Next, please. And it starts where in the surgical center in the hospital, and then you go through the doors that say surgery, and you're into a regular hospital surgical suite. About an hour and a half to 2 hours before the child or the patient is scheduled, you and your staff, or the dentist and the staff, will arrive and literally set up the operating room to resemble a dental operatory. In addition to that, on the hospital side of it, or the medical side, the anesthesiologist and a nurse will be there about an hour or so before, also setting up their equipment, which consists of an anesthesia machine, ventilators, EKGs, the works, so that they can provide medical grade anesthesia, general anesthesia to the patient, so that you can do everything you need to do in that one setting. That could be up to 30 procedures. Unfortunately or fortunately, sometimes parents want to come in and get their child eased into the situation. the child comes in and they're literally masked using general anesthesia. If you could go to the next slide, and the anesthesiologist will use a mask. And go to the next one, please, Jeanette. I'm sorry. And the anesthesiologist will mask down the child, and while that's happening, either I or a nurse will start an IV so that IV medicines can be given for sedation, and paralytic agents are used to prevent laryngospasms. So you can see it's a team effort. Next slide, please. Part of the puzzle of reimbursement and why it's so difficult to get these children in is that the anesthesiologist, next slide, oh, you have the right slide, sorry. The anesthesiology procedure is also a CPT code. And as you all know, CPT stands for Current Procedural Terminology. It's a product of the American Medical Association. So there's a CPT code for the anesthesia part of it, a CPT code, which is that 48199 for the facility, and then you have the CD codes for the dental procedures. Years ago, the state of Nevada decided to align itself with Medicare, and as you all know, Medicare doesn't provide dental care, and they don't provide any care to children. And here they're the ones that are deciding the relative difficulty of the work involved in getting these children under general anesthesia. It is kind of interesting. And Julie and I have 4 children and 3 physicians. And when I ask each one of the 3 physicians how much time they got in medical school for dentistry or oral health, maybe a total between the 3 of them is 5 hours total for their entire medical school careers. So you can see why some of these CPT codes are just skewed the wrong way. And there's such a lack of understanding by our medical colleagues, not because they are nefarious, and it's because they don't understand. Anyway, so on that slide, you'll see that the CD code for anesthesia that the anesthesiologist needs to bill for is 00170. And it consists of 2 parts, a base unit, which is a value compiled or decided upon by Medicare with regard to its relative difficulty and how much work it is getting these kids to sleep. And the way the anesthesiologist is paid is they get a base unit, which consists of a base cost, which is 5 of these Medicaid units, and then 15 minutes per unit for the time they spent in the operating room taking care of the child. They get nothing for the pre-op visit in the pre-op area, and they get nothing for the post-op area where they're getting the child back to normal. The state of Nevada has decided that their Medicaid conversion factor for anesthesia is $22.57. Okay. Unfortunately, most of the folks that deal with this don't realize that to take care of children or adults and do their dental care or oral health or oral surgery care, you have to have a nasal intubation. Next slide, please. That's where you put the tube through. Your child is pretty much masked down. They're heavily sedated, but they're still breathing. And the anesthesiologist will take a tube, an endotracheal tube, and put it through a nostril. And hopefully a toy dinosaur or a pencil eraser or a jelly bean will pop out into the pharynx like it has many times. But anyway, they put the tube through, and then you see the laryngoscope in the middle slide where we're looking to go to see where the larynx is, and then they'll take a McGill's forceps and guide the tube down into the trachea. It's really difficult on children because their tracheas are so far anterior. You can see in the middle slide the nurse's fingers holding the child's trachea or larynx area. Then the tube is secured. A head wrap is placed so that while we're doing the dental procedures, we don't scratch up the face. And then we also put a a throat pack in, because when you do a lot of dentistry, you make a lot of debris and saliva and liquids, and we don't want anything going down into the trachea and the lungs. Next slide, please. So the way they calculate the anesthesiologist fee is they take the base unit, which is that 5 units, which Medicare has decided what this procedure is worth, and then you take how much time it is. And most of my cases range from 90 minutes to maybe an hour and a half, maybe 2 hours, 2.5 hours, and that'll vary depending on whoever's doing the case. You get pretty fast as you move on in dentistry, as Dr. Putnam can probably attest to, and Dr. Van Orden can talk about. But anyway, so usually it winds up at around 11 units, and Medicaid rate for this procedure, or this conversion rate, is $22.57. So the anesthesiologist gets $248.27. The national average in 2021 for this conversion unit was between $78 and $84.50 an hour. So if you're doing a private case, you would get $858. If you're doing a Medicaid case in the state of Nevada, you get $248. Interestingly, when you look at the schedules in the Nevada fee schedule, you see that putting air tubes in, which requires no intubation at all, just masking a child down, the anesthesiologist gets 4 base units. So 4 base units with no intubation, just a mask, 5 base units for our work where it requires mask, intubation, a nasal intubation. It just doesn't seem to jive. Next slide, please. And this is what our cases look like. These are the children that wind up going to the hospital or the ambulatory surgical center. You probably see them in your practices every day as well. Next, please. So Jeanette asked me if I would talk about when I first came to Nevada with the Public Health Service versus 2024. In 1999, when I got here, the hospitals and the surgical centers were reimbursed $1,194 for the surgical suite or the operating room or CPT code number 41899. In 2023, as you know, it's $968. Interestingly, in 1999, when I got here, Medicaid had not aligned with Medicare, meaning they had their own fee schedule for everything, including anesthesia fees, which you'll see below. You'll see that the anesthesia fees or anesthesiologist fees were approximately $600 to $700 per case. And now with the realignment to Medicare, it's $248. A large discrepancy. I guess, we in Nevada don't have inflation. We're so lucky. Maybe that's why these prices went down. Anyway, I'm sorry I'm so sarcastic. This is only the second decade I've been dealing with this. Next, please. Again, the CPT code is owned by the American Medical Association, and they don't do dental procedures. So we wound up with this 41899 code, which is other procedures, and Medicare doesn't like it, and Medicaid doesn't like it. And we've asked the AMA, or we had asked the AMA many times, including the American Dental Association meeting with them, and the Pediatric Dental Association meeting with them to give us a code that would cover all our different procedures. So when you go into the hospital and you're getting a medical procedure done, there's a specific code. And if you have more than one medical procedure done, more than one codes are used, and each code is payable. We can do 30 procedures, as I said, and the surgical center gets paid for one code, which is this ambiguous 41899 code. Again, when you look to air tubes with regard to the facility, it takes 15 minutes to do an air tube or tympanostomy with just a mask. not a whole lot of supplies. The surgical suite or the operating room is not contaminated with oral fluids. And Nevada Medicaid has decided that they would get reimbursed $714.65 for a 15 to 30 minute procedure versus $968.15 for a 1.5 to 2 hour procedure. Next, please. And if you have any questions, please stop me. So I'm just going to walk you through how things went when I was doing these cases. So after the child was brought under general anesthesia and wrapped, and the throat pack was in place, because you couldn't do an exam in your office or a decent exam, you wound up starting all over while the child was asleep. So they got x-rays, exams. You can see my assistant Siobhan with me. And we would do everything that needed to be done, ranging from exams and x-rays to biopsies, space maintenance, surgical impactions, pulpotomies and fillings. Next, please. This is what our adults, our special population adults looked like. Nobody wants them, as you probably noticed, but we would take them as well. And they take a good amount of time to deal with as well. Next, please. We've had a computer set up, and most places bring computers. This was one of Dr. Clausen's patients from Community Health Alliance. And you literally have your own dental office sitting in there, set up for the day. Next, please. Then once the procedure is done, the child is brought to the recovery room where they're brought back from general anesthesia. They're recovered. The state requires to have 2 nurses at the bedside of the child while they're recovering, plus the anesthesiologist. This requires between 15 to 45 minutes to an hour. It requires a lot of teamwork between the dentist and the anesthesiologist, and then while this is happening, the room is being turned over so you can do your next case. And if you're the only case, then the room has to be literally disinfected so that a medical case can go in there. If you have private insurance or you get private insurance for that code, they wind up getting about $5,000 per case. Next, please. Again, that fee that they're getting paid, that the facility is getting paid, includes paying for nurses. You need at least 2 nurses in the recovery room, and you can't just say go home between cases. And then you have a nurse in the operating room the entire time to assist the anesthesiologist. So it can cost like $300 or so just for each case, not including all the standing around time that the nurses are there all day. Next, please. This is a copy of the Federal Register announcing that our pleas to Medicaid and the Centers for Medicare and Medicaid had been heeded, and they took a HCPCS code for our services, and they suggest paying like about $2,000 per case. Unfortunately, this will take care, or fortunately, this will take care of the surgical center in the hospital, but the anesthesiologist CPT codes will be tied to this, and unless they're improved, we've only got like 1 piece of the puzzle or 2 pieces of the puzzle taken care of. You can have the nicest facility in the world, but without an anesthesiologist, how are you going to take care of these children and special care adults? Next, please. It made it to the literature and the pediatric dentistry literature in the last issue of Pediatric Dentistry. It's making an impact not just in the access to care issue, it's making an impact with regard to training pediatric dentists. Unless you can get into a hospital operating room, these pediatric dental residents or students are required to do a certain number of cases. but if they can't get in, they can't finish their training. So next, please. And that's what's happening in the United States today. If you go to the Nevada Medicaid website for fee-for-service reimbursement, we're told that they're paying about 65% of the charges that dentists charge for children. As you may know or may not know, the median dental office overhead a couple of years ago was almost 62%. That's not a whole lot of wiggle room. And then dental services nationally are only 4% of CMS or Medicaid services. Next, please. So anyway, I was asked about, does the legislature have to approve going from fee-for-service with CPT codes to HCPCS codes? If you go to the Nevada Medicaid website, you'll see that in other healthcare areas that Medicaid covers, such as medication usage, there's a requirement to use the HCPCS codes. So they're already being used by our state Medicaid folks. And then in addition to that, you know, hospital dentistry, if dentistry is only like 4% of the national Medicaid spending or the state Medicaid funding, in the hospitalization of these children and special care adults is maybe 2 to 3% of this 4%. So it's really a small number when you compare it to all those people out there that are getting dental care through Medicaid. Next, please. So we do have some opportunities here. If you've read the newspapers like the Nevada Independent, you'll see that beginning in 2026, all counties in the state will be moved to managed care. Right now, the majority of the population is in Washoe and Clark County, where there is managed care. And you'll see the names of the different managed care organizations on that slide. Okay. Interesting, with regard to fees and money that's available in the state. If you all remember the subprime mortgage recession about 15 years ago, Nevada, in order to save a good amount of the state budget, decided to drastically cut state workers and their dental insurance benefits. And that impacted the state workers, obviously, but it also impacted the state dentists. What happened was, using lobbying efforts, hundreds of millions of dollars somehow were found in the state budget, and those benefit cuts were all gone away. And we were told it was just chump change for the state. So if you can find the chump change money for, you know, these benefits, you can find it for these children who've got nowhere to go, and it's not their fault that they wound up with such pathology in the mouth, or the special care adults. Next, please. When you look at the requirements of the managed care organizations in their contracts with the state of Nevada, they're required to have a floor rate, or a rate floor, or directed payment, which means that they've got to reimburse the dentists and physicians who provide care for Nevada Medicaid patients at least as much as Nevada Medicaid is paying. And that was even put in the newspaper in the Nevada Independent last year with an interview with Stacy Weeks, who was then the Medicaid administrator. When things started to go south in 2018 and 2017, in that period of time, we meaning the folks doing hospital dentistry, were able to get the managed care organizations in Clark and in Washoe County to increase the reimbursements for the anesthesiologists and for the facility fees. So that does happen. And as you probably know, there are lots of short-term fixes out there. So this did happen at one point. It doesn't take a legislative session to decide on this. Next, please. You might recognize the name of the administrator cited here. As part of the AC4OH, we spent months trying to figure out what the state dental health officer would be doing and what the requirements of the job should be. Anyway, so people applied for the position, and at the end, 3 people had applied, some with lots of experience, some with no experience, some with licenses, one without a license. The person selected didn't have any of the things that we required, but was hired anyway. And when we contacted Cody Finney, who was then the administrator, we were told, we are the state of Nevada, we can do whatever we want. Thank you very much, have a nice day. So things can be done, and it doesn't take a legislative effort. It just means we need to figure out the right person in the legislature to talk to, or the right person in the Division of Public and Behavioral Health, or Division of Healthcare Finance and Policy to talk to. I would hope that the dental health officer could just literally pick the different codes that we utilize, and we don't need another alignment. We just need to adjust some of these codes. As you saw with the ear tube numbers versus the oral health numbers. Anyway, I'm hoping I didn't talk too much. I'm happy to answer any questions, and I'm hoping you now understand the parts involved in getting children taken care of in the hospital. And I'll answer any questions as best I can.
Thank you so much.
Oh, you're so welcome.
Yeah, thank you, Dr. Rosenberg and Julie, for being here and giving us some of that background. You guys really know this and have been around for a while. So we'll take some questions. Looks like Gina Hernandez has a question. Go ahead, Gina.
Hello, this is actually Dr. Wickers at Sun Valley Surgery Center.
Hi, Dr. Wickers.
Hi, that was a very good presentation. Thanks, Mark. And he hit like most of every point pretty much. So I appreciate that for him kind of raising awareness. And we've met with you guys in the past. One thing to be clear, even though that G code has been adopted by CMS, it has not been adopted in Nevada yet. So I just wanted to make that clear. So facilities aren't getting that G code yet. So that's a struggle that the state did outside of the legislature give us a moderate increase about what we were getting paid in 1999. So they have given us, but it's only a year. So it'll phase out after a year if the state legislature does not pick up a new rate. And so while we have gotten a little increase, which is helpful, the problem is like Mark said, anesthesia. It's very hard for us to get anesthesia coverage. Our facility alone probably does 80% of the cases in the whole state, special needs and pediatric patients. And I think the only reason why that it is still going is because Dr. Garicachia and I are both anesthesiologists, and we've essentially donated our incomes the last 4 or 5 years because we're not getting paid. Well, you know, we have a anesthesia group, and we used to kind of divvy it out among each of us so that each of us cover this facility an equal amount of time. But now that there's been such an anesthesia shortage and stuff in the state, none of our partners are willing to come here anymore because they just don't make enough money. So it ends up being that Garicachia and I are here a majority of the time. And so so essentially we've had to donate our incomes to to kind of keep the place going. And we've talked to the state. They did give us that temporary increase in the facility fee, but now we're just having to pass that on to the anesthesiologist as a kind of a stipend to help them to be able to help cover. So I mean, we're greatly hoping that the state will adopt the G code and that the facility can get that higher reimbursement and that something can also be done about anesthesia. If they do adopt the G code, we know that it'll essentially go towards helping incentivize anesthesia to come here. So we've been told by the state, they've listened to us, but we've been told that they can't do anything without the legislature, which wouldn't happen till 2025. And they said it's kind of out of their hands, that they told us to talk to state legislatures and the governor, whoever we can, so that they can increase the budget. But anyways, I know we've talked in the past about getting a letter from AC4OH to help. I know they're in the middle of making the budget now, but that letter would help. Also, even if Medicaid, Stacy Weeks and stuff, if she could see this presentation from Dr. Rosenberg, I think that would be helpful as well. As many people that could see his presentation would be helpful. So that's kind of where we're at right now. And I appreciate you guys all giving us the platform to be able to kind of get this out. So
I can't speak about the South, but our way of getting around this problem was Community Health Alliance. At one point, we actually hired an anesthesiologist, a semi-retired anesthesiologist, who worked with us for about a year. We also realized that one of the hospitals in the north, Renown, and St. Mary's, would still let us do cases there. Renown receives county funding and state funding because it's a tertiary referral site and a crisis area. And we were able to leverage ourselves in that way into that part of the state. I used to have block time at St. Mary's. Unfortunately, St. Mary's was sold and became a for-profit organization. We would see children 3 days a week. But there are ways we might consider for the anesthesiologist. I don't know how much debt they graduate with, but anesthesia is not considered fundable by the National Health Service Corps or the Nevada Health Service Corps or the new treasurer's loaner payment site. We might see if maybe by a stroke of the pen, if we could extend that loaner payment, which I know is only $25,000 a year, but it might be the difference in helping some of these people want to help us.
I mean, I can speak for ourselves. We only have 2 operating rooms, but we see over 3,000 patients a year at our facility with just the 2 operating rooms. And we've had providers ask us for more time, and there's only so many days in a week. We've talked about opening another facility to help out, but the cost nowadays, because of inflation, to build a new facility would be just outrageous, especially at the current rates. If they did raise the rates and they took care of the anesthesia problem, then I mean, because we've talked to some of the dental groups that need help up north, and we've said, if those rates were increased, we could probably help. We'd be willing to go up north and to help out up there, but at the current rates, it's impossible.
Bryce, you were in Elko for a long time, and you referred patients, I believe, into Salt Lake, not to Reno. How did that work? Were they willing to take our cases with Nevada Medicaid rates such as they are?
So that's just dependent, because what would ultimately happen is that we have pediatric doctors, dentists here that would do as much as they can, and then they would get rounds with the Northeastern Nevada Regional Hospital here, and we're allowed to do that. That was about 2 years ago. The new group of dentists now are going away from that, especially with Medicaid. They do as much as they can in the office. However, the University of Utah is still taking those cases, but it's because they have a residency program there, so they're able to do a little bit more. So we're able to send some of those people, especially our kids, and but most of those, I see as many as I can for what I can do. But if not, they either have to go to the pediatric doctor, and if dentist, and if they can't do it there, then it's University of Utah, or certainly they even look down in Las Vegas. So
oh, go ahead. Sorry.
no, I'm looking at this, and because I want to write a letter, but I'm seeing, is the system broke? Because what I'm seeing is not a system that's strained. We have a fundamental infrastructure problem that is not sustainable. And what we have to look at is if these rates, or if we don't find a viable solution. And I like the National Health Service Corps option. But if you don't find some sort of solution, it's icky for anyone in the state to alienate children and people with special needs. So, there has to be some sort of solution, because the solution of Dr. Wicker's not being able to take these patients anymore is detrimental to all of these people, which is, certainly what we don't want, because all of us are trying to find solutions, and we go through whatever avenues we can do to get them. But however, do I follow up with every single patient? No. So does that mean that some of the patients that I sent to University of Utah or to some of the pediatric specialists, were they taken care of? Yeah, some of them were, but a lot of them weren't. And that breaks my heart. That's where all of us have to look at and say, the ones that we are missing, that are living with dental pain, dental infections, having all of these issues, based on a fundamental system that should be able to be changed from just empathy. That's where I'm coming from, is, who do we talk to? And that would be my question to you, Dr. Rosenberg, is if you or us, because, we can write a letter, but, what is the most impactful way to move forward? Because I know Dr. Wickers has come before us. He's set the leadership standard, as far as I'm concerned, for the state to help these individuals. What can we do to support him, and not just him, but others, so they can come in and do it as well?
If you know how the legislature works, things are done way before the session starts. It's time now to start approaching all the different legislatures in the Senate and the Assembly. In addition to that, if you remember, right before the dental school was started, Dr. Rawson went around and testified before the legislature, promising that, number one, the school would be in the rural areas taking care of children, and number two, they would be taking care of all these special populations. I didn't see a whole lot of that happening, but we have a new dean now, Dean Ma, and perhaps it's time to invite him to one of the AC4OH meetings and ask him if he could get involved. I know that for the special care area, I believe Dr. Tabrizi is on this call, and I believe the state, the dental school, is actually building an operating room set of suites to deal with special care patients. And I also know that the state has a pediatric dental residency that should be seeing some of these patients. Perhaps they need to take a role also. And I think that it's time to approach them and ask them to join us. It shouldn't be them versus us. Sorry, Mary, to get you involved. I couldn't help myself.
No, that's okay. You have no idea how happy and impressed I am that you're bringing the issue up. Yes, I have started something very small to at this school to, as you said, kind of get ourselves into it and have the registration and the state look at us. But you definitely have enough documentations by far to actually lead this, if you want to call it, movement, and pay and do a little bit more than just shedding a light on a problem, but have a direction and going somewhere with this, because we all know the need is there. And I cannot believe that Medicare becoming part of a Medicaid and actually uh, paying less, because, as you said, Medicare doesn't cover children and doesn't cover dental. So yeah, we need to come together and address the issue. And again, I really appreciated what you're bringing up, and honored to be here to hear all that.
Tara, what is Indian Health doing these days? Who are you referring to? And you're probably using contract health money plus Medicaid.
Yeah. Hi, Mark. Yes, we are referring to private practice pediatrics and either Medicaid or PRC, which was contract health. Now it's purchase referred care. But those two funds are what we use. And even with our pediatric offices in town here, they're booked out pretty far for any sedation cases, as far as I understand it, because it seems to take a long time for the kids to get in. We do everything we can here, but anything, we just go through the private practice sector.
Thank you. I would start at the higher levels of healthcare finance and policy, the governor's office, the different legislatures. They can pass any laws that they want, and they can change things for you. But as I said, with the first Medicare realignment or Medicaid realignment to Medicare, when Chuck Duhart was the head of healthcare finance and policy, I had just retired from the public health service, and he told me he was directed, or that they were directed by the feds to align. And when I called my colleagues who I had mentored in Washington, there was a silence at the end of the line saying, I'm sorry, it doesn't take us. It's all voluntary by the state of Nevada. They don't have to realign. They never had to realign anything. And each fee was determined by the state of Nevada, not by Medicare. Those were just suggestions, apparently, to be used for adults, not children. That was the lecture I got from one of my younger colleagues. So all this can be done. It doesn't take a legislative act.
Just to bring up one thing that you guys were talking about, cases going to University of Utah. I actually know a dentist in Utah, in Orem, Utah, Bruce Howell, and he gets a lot of patients from Elko, Medicaid patients from Elko that he does at his facility, and they pay him though $1,700 per case for the facility fee at his facility. So I know that, you know, there's a lot of patients that are going outside of the state. I know that's a little bit off subject, but I wanted to bring that up as well. So
Terry, you had a question, it looks like.
I
Your
do.
mic is off.
Thank you, Dr. Rosenberg. I appreciate the information. Always great to hear from you. And I love that you have so much history and you're still willing to.
It's because you get old.
Well, me too. But I love that you share it. So I do. So what year was it when Medicaid aligned with Medicare rates? When did that happen?
It was several times. The first time was probably around 2007 or 2008. Then it came again. I believe Jeanette actually pulled out the MCAC, the Medical Care Advisory Committee meetings from 2019 that I appeared at. Several years before that, it got aligned again. I guess aligned means that alignment probably is a different term for to use to reduce fees. Um, and it is interesting that Chuck Duart actually attended that meeting with me. He was smart enough not to sign in because I don't see his name as in attendance of that meeting. And he asked his successor, our now head of healthcare finance and policy, he let her know that he thought it was a mistake to do this. And could she change everything back for the anesthesiologist and for the facilities? And she said she would think about it. Obviously, things are still thinking. This was Suzanne. Suzanne had just assumed her position at the time. She's still director of healthcare finance and policy. We probably need to invite her. You're welcome to use my presentation. I've got plenty more pictures of my patients. I tried to catalog to keep them because people don't believe you. You know, when you talk to people who are in our social strata about these kids, they go, well, my kids had one cavity, or my cousin's kids had, you know, one cavity or two cavities, and they're getting sealants. They don't imagine that they look like some of the stuff I showed you today, and how painful it is.
I totally get it. So it's sounding like there's a lot of history with this alignment with Medicare rates to decrease rates in Nevada. Is there any way we could roll that back and eliminate the alignment, or is it just too much time has gone by?
That's why when we were on AC4OH together, and we strategized about the state dental health officer position, and we asked the legislature to make sure that that person that they hired had extensive experience and had a license, so they had been treating patients. That's what we thought, that person could go through all these lists and change these numbers, because some of them are just absurd. Ear tubes at $700, but an hour and a half to 2 hour case, $900? It doesn't make any sense. And the same for the anesthesia part of it.
I agree with you. I'm just trying to come up with what the solution might be.
Perhaps Dr. Benson can view this and maybe meet with Suzanne and say, look, we're not asking you to realign. We're just asking to change these numbers, these units or values.
Would it be possible for you and Dr. Wickers to provide the AC4OH members with a bullet point list, since you both have the expertise, so that we can also try to be your advocates and champions with not only the legislatures, but healthcare finance or whomever else, because we all have our own circle of influence, and I want to help correct this. It also helps me to know how long this history has been in existence. So I started with the oral health program in the year 2000, which, my gosh, it's almost 25 years. That's a while. But it looks like shortly after my tenure with the oral health program, a lot of these things started happening. And that would be my ask of the two of you, if you could give us some bullet points.
I'm happy to work with Dr. Wickers. I've worked with him in the past many times, obviously. We've gone through this time and time again.
Thank you.
Terry, just speaking to what you said, right now, actually, we wouldn't mind being aligned with Medicare again, because Medicare is now suggesting $1,700 for a facility fee. So almost double what we were making. So, you know, it's interesting that the state wants to align with Medicare when there's a decrease, but when Medicare suggests a higher rate, they don't want to align with Medicare. But aligning with Medicare right now would actually be an advantage to us. So,
well, and that's the expertise we need. We need to know what it would take to find a solution that would improve the situation so that our kiddos can get appropriate care. The other thing that I worry about, which we haven't talked about, which is another outlier, is Nevada has so many uninsured children. There's a small percentage of kids that are covered by Medicaid, but then there's another pocket of kids that aren't even enrolled, eligible, barriers, what have you, and they're completely uninsured. So my nonprofit keeps stepping up, trying to take care of them, but it's not easy.
Yeah.
Well, if I can make one more comment, I think Dr. Rosenberg already addressed it, is the fact that dental procedures, they are all bunched into one code or called others. I think the most uh, logistically, what's important is to be able to call dentistry as a part of healthcare and actually itemize this services, call those items codes, so they can actually be recognized as a procedure, what's needed, and that's pretty much the foundation of a lot of limitations. So that may be a avenue to step in as a um, recognition and be able to code things and procedures.
Mary, you're going to be involved with this as well with your surgical suite, because most of your patients probably have Medicaid as well.
Well, that is correct. But as you said, our I don't know honestly when that suite is going to be built. We have the funding, but the funding is basically for the physical um, clinic. I don't know how it's going to be helping us with the procedures and the payments. And school is just still part of it, whole state legislations and involvements. If we won't be able to build what we need to build, we're back on the square one. So kind of we need to change the way dentistry is looked at in all ages, from children then um, 65 plus. That as Terry was just saying, the majority of kids are not covered, and most certainly nobody over age of 65. So I'm very new to this state, but I definitely can see the issues, and I'm here to whatever I can do to make a difference.
Thank you. Are there any other questions? And then I'm going to excuse myself from heading down to Tonopah to do some more karma payment plan work by providing care at their clinic. Thank you so much for inviting us.
Thank
Nice
you
seeing
so
you all.
much.
Thank you.
Thank
Bye
you.
now.
Drive safe. Thanks.
Thank you, Dr. Rosenberg. See you, Julie.
All right. Dr. Bryant, are you there? Okay. I will go ahead. The next agenda item that we have is update of the oral health program. So let me see. I'll start off. Dr. Benson wasn't able to be at this meeting today, so I will give his update first. For the IDD waiver, we've reached about a quarter of the participants from January 1st, 2023 through December 31st, 2023. So that includes 788 recipients, 1,302 claims, and 199 rendering providers. There were 499 exams, 316 cleanings, 298 deep cleanings, 374 fillings, 6 root canals, 564 extractions, and 42 dentures. He's working on adding procedure codes to the ID waiver. That is ongoing, and rates and system challenges still exist that have slowed the progress. We did ask HRSA through our oral health workforce grant if we could use the carryover funds to supplement payments for IDD providers, but since that wasn't one of the programs written into the original grant, they wouldn't allow for that. DHCFP has completed a letter of agreement with Summit Surgery here in the north to add more dental days per month for the next 6 months. So they'll run that as a pilot to see how that goes, which is good news of trying to get some more of those kids to get treatment. And they've also completed a letter of agreement with the Sun Valley Surgery Center, as Dr. Rosenberg, Dr. Weikers have just discussed with those rising costs. So for the Nevada Oral Health Program, We now have a management analyst on board. Her name is Shannon Canfield. She wasn't able to make this meeting today, but she's going to be there to help us with all of the grant management, some of the program sides, and she's being funded through the HRSA grant as well. So it's really nice to have that support. Through the HRSA grant, we are doing a pilot dental assisting high school program in Elko. So we're working with TMCC, we're getting contracts finalized, and it'll be a 1-year introduction to dental assisting to get students excited about the profession, get them interested in dentistry, so they can continue on to work in the profession, or maybe go on to dental hygiene school or dental school. Jessica's Public Health Collaborative has been moving forward. She just had a great CE on SDF and Curodont and different public health mechanisms that we could be using in the rurals. So that was really great. She came to Reno and she had one in Las Vegas. And then we have the Tonopah Clinic that Dr. Rosenberg is off to, which we are still looking for volunteers, but it is up and running and they are seeing patients. So that is some good news as well. March 2nd, we're hosting another CE event with Dr. Wong at Roseman University, The Joy of Treating Patients with Special Needs. It is free, so if you're in the Las Vegas area, please register for this event. He's an amazing speaker and just really motivating. So that'll be our last project with the IDD. That's going to be ending end of March, the project that we had going with Cindy.
What is that day? What is the date and time at Roseman?
It's March 2nd. And I can
Excellent.
send you the flyer if you need it with the registration information.
that
I'll
would
send
be
that
great.
out.
This is
I'll send that out to everybody. Jennifer, okay, great. Thank you. Let's see, we just finished inputting all of the BSS data. So Siobhan, I think, is on the line. She's a student at MP with getting her MPH from UNR. She did her internship with us and she helped me input all that data. It took quite a bit of time, but we finally entered it all and we're going to send it off to ASTD to analyze it and give us a report. So that'll be available by the end of March. And then I'm looking into, we have a little bit of funding left for this next fiscal year. It'll be our last year where the oral health program is funded through Healthy Nevada funds. And I'm considering doing either a special needs population BSS or a kindergarten or older adult population BSS so that we can get that data. Sorry, I just need to let somebody in here. Let's see. And then we have been really busy the last few months. We applied for a HRSA grant, the Improving Oral Health Integration Projects grant, which is a medical dental integration grant. And I just really wanted to thank Lynn Short. She mentored me through the process. This was the first grant that we wrote through the oral health program. It was successfully submitted. It was a little stressful there at the end, but we did get it in. It was a 60-page application. And Dr. McCarthy and Dr. Cucolon Calderon, thank you so much. They came to the stakeholder meetings and they provided letters of support for their clinics to be involved with this grant. The target population is pregnant individuals and children under the age of 1, and it's providing that preventive oral health service in the medical setting with a follow-up dental referral. And Liberty Dental Plan was also providing us support for that referral mechanism to ensure that these kids will have a place to go and the pregnant women. So this really just highlighted how important it is to have this data on hand. I referenced the state plan several times to get data from there. You know, having the EC4OH members present and involved was, you know, very impactful. So thank you everybody for that. We'll find out if we get this grant in June, and it would start in July of this year. So I will keep you updated. There are only 7 awards, so it is very competitive. But the fact that we have an application and we've got it submitted, I think is a great accomplishment. And it's also great to have that application on hand for future grants because we can pull out a lot of that narrative. So we'll keep that on file. As far as the state plan goes and the objectives, I'll be meeting with Dr. Benson and Shannon to pull out what we'll be focusing on this year. But some of the things that we're already doing include supporting oral health coalitions that are active in our state. Lynn provided a nice presentation to the Maternal Child Health Coalition, and I'm working with the Nevada Cancer Coalition as well. So we'll have to keep them updated and just let them know the importance of oral health and put that on their radar at these meetings. We're also working with Fuel Up Healthy Go, which is an educational program focused on nutrition and physical activity. And it is a resource for teachers to use in their classroom. So we will provide them a presentation to discuss oral health in the classroom, some resources for parents, an oral health lesson with activities, and this will target kindergarten through 5th graders. I think that's it. The last thing I wanted to mention is one of our state plan objectives was to have a statewide needs assessment, and we will meet that deliverable through the HRSA oral health workforce funding. If we get our carryover funds approved, we will hire a contractor to do that statewide need assessment for us so that we have all of that data on hand and updated. And then lastly, Dr. Benson and I are working with Office of Analytics and as well as Lynn to have an oral health dashboard that includes all of the oral health data, all of the sealant program data that we have in our state, as well as some of the state data, including PRAMS, BRFSS. So hopefully we'll get that up and running soon. So does anybody have any questions for me? Okay. So I think, let's see here, we did that. Next up is agenda number 8. Lynn on the update on American Rescue Plan Act funding for school-based oral health programs.
Thank you, Jeanette. And while I am very grateful for your acknowledgement of my assistance with the grant, I do want to let everybody know that Jeanette was steadfast in getting this grant written and done, and the number of collaborations as well as partnerships that she developed in a very short amount of time to not only support the grant, but also the work within it if it's funded, or when it's funded, I should say, was amazing. So congratulations to Jeanette. For all of the hard work that she did. As many of you know, we were awarded $2.7 million in ARPA funds in order to expand school-based sealant programs and reinstitute school-based sealant programs that may have been disrupted due to the pandemic. And so in the first 3 months or 4 months, we had 8 subrecipients who submitted their first semi-annual reports for work through December 31st, and we documented the following data. 1,512 children and youth received an oral health screening during that time, and I will be very honest, the contracts did not go into effect until September 1st. And with school starting, many of these programs did not even begin until seeing children until mid to late October. So this is where these numbers are derived from in that short period of time. 741 children and youth received dental sealants. 2,696 dental sealants were placed. 1,249 children and youth received oral health education. And 49% of those children screened had untreated tooth decay, which I think is really telling in regards to the importance of these school-based sealant programs, and especially those targeting second graders and 6th and 7th graders in regards to trying to get newly erupted molars sealed. Schools that were served during those first months of the program were located in Clark, Humboldt, Lyon, Washoe, and White Pine County. And by the end of this school year, when we have another report due by our subrecipients, which would be at the end of June. We expect 12 of the 16 counties, including hopefully Carson City, to be served by our school-based programs, which leaves just 4 counties that have yet to be served. We will be releasing another RFR. The plan is to do that for funding for the school year 24-25. We hope to release that RFR by mid to late April. There will be some changes within that RFR, of course, based on some of the experiences that we've had, the learning that we've done. So that will be updated and released at that particular time. And again, it's for another school year. So we're looking forward to that. We did receive approval to extend our funding through June of 2026, which is very, very exciting in order to be able to continue our support for existing school-based sealant programs that we've already funded and any other new school-based sealant programs that may be out there in the coming months. So does anybody have any questions at all? Thanks for the opportunity to provide the update. Oh, Jessica.
Oh, I didn't hear you. Did you say Pahrump in the counties that had been served?
I did not. I said Nye County in the counties.
That's what I meant. You said 9.
Yeah.
Okay, I'm sorry.
Yeah, I actually
It's
didn't
Friday.
specifically. Yeah, yeah, not a problem at all.
Okay. I'm ready for the holiday weekend.
Yeah, not a problem.
Sorry, missed that.
Okay,
Great. Thank you, Lynn.
you're welcome.
So now we have organized dentistry update from the Nevada Dental Association, Jody Metzger. Thank you for waiting and adjusting your schedule today.
Of course, of course. Thank you for having us. We're very excited. The Nevada Dental Association's been very busy working on writing regulations for the bills that were passed last year. They include SB 310, the EFTA bill, AB 147, modernization of dentistry, SB 393, medical loss ratio. I know that's a big deal. And SB 432, board reform. The work is being done with the Council on Government Affairs in conjunction with our legislative firm, Tri-Strategies. We are also looking into the compact. I know there are 2 floating around. The board is leaning more towards the ADA one. But I had a meeting with the ADA the other day and I asked the question, can we do both? They said, yes, you can. If they wouldn't recommend it, but you can. So far, no state has signed up for the other one that the is it the AAGD or AADB? I forget, put forward. But there are 4 states signed up with the ADA compact. There are 7 more that are going in this year for their legislative session. Of course, those do it annually. We, of course, only do it every other year. So we'll have to wait till 2025 to put ours in. But anyway, that's what we're looking at. We had a presentation on the other one on our board meeting that happened last Wednesday. So the board is not really interested in promoting that one. So we're looking into that. And we're also looking into getting more students from the UNLV, of course. We're participating in the signing day coming up in April, I think it is, or March. I think it's in April. Next year, 2025, is our legislative session. And the areas we're looking at workforce shortages, dental program enrollment, and insurance billing issues. These are 3 of the things we're looking at as possibilities to go with for 2025. If you all have any other pain points, please shoot me an email. I'm happy to share that with the CGA. We've surveyed our members and just in talking with different dentists, these are the things that have popped up as issues in Nevada. So that's what they're looking for doing. And that's really my update. We've had our House of Delegates meeting. I don't know if you're interested in that. We had our House of Delegates meeting in January, and our next one is coming up in June, where our EC will roll over. So is that a good update?
That's great.
Okay.
That's wonderful. Thank you so much. Does anybody have any questions?
Or any topics you would like us to cover for next year? All right. Well, thank you very much. I appreciate it.
Thank you. So up next, we have organized dentistry update from the Nevada Dental Hygienists Association, and that is Christy Davis now, and she let me know that she would not be able to attend today's meeting, but I will provide you with the update that she wanted to share. So they are waiting to hear about the activation of the Advanced Therapy RDH and the license compact that Jody had mentioned. The northern and southern components and the state association has created a phenomenal program this 2023 through 2024 session with a.
Are you there?
Oh,
yeah, but it's okay. I'm muted and I'm hidden. Oh. I've already given my update. I'm good.
Mute. There we go. Let's see. So they're providing a vast array of continuing education courses, meetups, and events. The first oral cancer walk will be held April 28th, 2024 in Henderson at Cornerstone Park. They are hosting a poker and paint event in Reno Sparks in Mite, as well as hats and bow ties derby event that will include a silent auction. This is in addition to the Saturday webinar series, as mentioned, and the continuing education courses. The Nevada Dental Hygienists Association works closely with the dental professionals and are actively seeking to reconnect. And they have been in talks to partner with Colgate for an event for children, but there is no events right now through the Nevada Dental Hygienists Association. And I think that is about all that she had. So I will move on to Dr. Arian to provide an update for Liberty Dental.
Thank you, Jeanette. Good morning, everyone. Today we will be presenting information regarding our population health management program. This program was established in 2023 with the goal of improving oral health outcomes for our members. The program mainly focuses on preventive measures, health education, access to care services, and addressing social determinants of health, such as housing, education, and other social and economic factors. We rely on strong partnership with healthcare providers, community organizations, and other stakeholders to implement intervention and initiatives that would promote better health outcomes across all population, regardless of their race and ethnicity. To speak more about this program today, we have Chris Perot, the Population Health and Equity Program Administrator for Liberty Dental Plan. So, Chris.
Hi, thank you so much, Dr. And just thank you to the committee for taking the time to allow us to give a brief overview of our population health management program. To get started, I just wanted to give an overview of our program, and then I'll go into giving details that reflects and disease, creating health equity and supporting efforts to build more resilient communities in Nevada. So what is Liberty's approach to combating this? Our approach starts with assessing the needs of the population we serve, stratifying our members through our risk assessments, implementing targeted interventions, engaging our participating network providers, and measuring and refining our program through continuous evaluations. So through our population health and liberties quality strategies, continually reviewing how to assist in funding the state's quality strategy. This is improving the health and wellness of Nevada's Medicaid population through the use of preventatives, increasing the utilization of dental services as well. Now I want to go ahead and talk about our program tools and resources. The Population Health Management Program integrates collaborative engagement within our organization, community stakeholders, and our provider network to achieve our population health management program goals and objectives. One way we do this is through our member assessments. Our member assessments is integrated into the development of our membership file, which is the health assessment of our member and an assessment of the community determined among specific demographic scenarios. We also engage our providers through collaborative engagements. Liberty seeks to improve the provider member experience overall. We also have different interventions, either through our bonus programs targeted at members or our providers. And we also target interventions to specific demographics. We also conduct community outreach. Our community outreach team, Liberty, has established a presence in the communities to our members to provide direct or indirect resources, and then resources to all members. We've also launched our Community Smiles program that is free to use for. Next, I want to talk about just developing our membership profile. If anyone has any questions for me, please go ahead and stop me. Feel free to ask. So next, for our membership, a high-level overview of our membership. We do this to understand who our membership is and how to best serve them. So we take different points that includes our race and ethnicity, the spoken language of our members, the age group that make up our members, and then also the county breakdown where our members reside, and also the health of our county as well. Next, I want to talk about our member needs and resources. So I talked about our membership profile. The way we develop our profile is through different health assessments. We provide a variety of assessments with multi-layer members of our members' utilization claims data, language surveys, and just health surveys, just to name a few. Member health risk. We also do an assessment of our community that includes severe housing problems, the number of uninsured, and as well as children with parent households. Next, we also engage our providers. So we engage our providers through provider training. We want to establish cultural and linguistic competency, ensure our providers understand the population. We also establish our brush program to provide provider incentives, establish our providers to conduct outreach, and just incentivize them for helping us improve utilization. And we also have different interventions geared towards members that include text campaigns and welcome calls that help provide members detailed information on their benefits, as well as helping them get a dental. And finally, for our community outreach, our outreach has been able to establish a presence within our community, within offices, as well as Google programs provide health education information. Okay. Are there any questions? I'll also drop my contact information in the chat as well if anyone would like to reach out to me.
Great, thank you. Okay, so next up we have, is that all, Dr. Arian, or did you have anything else?
No, that was pretty much our presentation on the population health. Thank you.
Thank you. So next up, we have Sun Valley Surgery Center update of general anesthesia cases in Las Vegas. This is informational. Dr. Weikers, did you have anything else to add? Or Gina? I don't know if they're still, it looks like they're still on the call.
Hi, sorry about that, Dr. Wickers. Getting him, he had to step to the bathroom. I apologize. Well, thank you for all your support. It was a great presentation earlier from Dr. Rosenberg, and Dr. Wickers spoke about a little bit of pretty much of our update. We have talked to Stacy Weeks, like stated previously, and we did get a relief on payment for a year. We got a letter of agreement to help us out. Dr. Wickers is here.
What am I saying? Sorry, I just stepped out.
No problem.
Go ahead. I'm sorry.
We have you on the agenda for an update, so I wasn't sure if there's anything else you wanted to add.
Not really. I think that between me and Dr. Rosenberg, we kind of covered everything.
Well, thank you so much for being here today.
You're welcome. Thank you.
This leads right into agenda number 13 for the discussion regarding AC4OH letter to support for Sun Valley Surgery Center and approval of letter for support. So I know we've had this on our agenda the last few meetings, and now that we have some background information, if anybody wants to lead that discussion from the committee.
Yeah, Jeanette, this is Dr. Putnam. I certainly can.
Thank you.
I think with Dr. Rosenberg's presentation, I think that was very insightful for all of us. I know that Dr. Wickers has talked for the last couple of times. I think that, knowing where we were in 1999 and where we are now, I think some of those bullet points that Terry had asked for between Dr. Rosenberg and Dr. Wickers, I think that would be exceptional for us to have to add to the letter. But just hearing that, a realignment between Medicare and Medicaid payments, like it was done, and if there was, and this is something that I would like to ask Dr. Wickers, because I have gone through some of the old archives that Jeanette had sent me. Was that ever stated in public that they were going to align Medicare and Medicaid payments moving forward?
I don't know if it was, I know that the reason for the last decrease was to align with Medicare.
Okay.
But now they, of course, don't want to align with Medicare now that Medicare is much higher.
Yeah, and I think that's something that we can at least ask about, because if we're going to align, we can't align we have to be consistent.
Yeah.
And I think that's something that could certainly be asked through a letter. And I think that with just some of the history and some of the bullet points, I think we have enough now to truly write that letter. Having heard Dr. Rosenberg and making sure that all of us are on the same page, because I have no problems, leading that effort. Like, a couple meetings ago, I had volunteered with Dr. Collier to do that. I have no problems doing that. I just wanted to make sure that all of us were aware and on the same page moving forward, because what I want is, and I think what the advisory board wants is to establish that there is leadership within the state of that there's one surgical center that's doing 80% of the cases. With that being said, that's not a long-term solution. We need to have others to be able to join in, and we have to be able to do that, or these services will no longer be done. And I don't think that anyone from the state would want that as well. So writing the letter to say that we have a statewide issue, that it affects rurals, north and south, and that in the past we have aligned payments from Medicare and Medicaid, that we really need to go back and do that again. and then really honestly present something that says in the future, we need to make sure that these are aligned appropriately, and to understand that by significantly decreasing these payments, we are, the underserved population in the state of Nevada will be affected. And I think that that's my interpretation of how I would move forward. But I want to hear from other members of the group to say, is that something that we're all willing to do? And then we can finish that letter. Terry?
Dr. Putnam, I am very much in favor of drafting this letter and having it come before the AC4OH for a vote and moving forward. There's a piece in there that I'd love to see that we include. So the oral health program and Future Smiles have been working with the Nevada State Department of Analytics, and we've been trying to extract emergency room data regarding children and adults utilizing the ER room for dental emergencies and what that cost is. So we should have, right, Jeanette? It should be coming soon, data on what is the other side of the coin here. Yes, it costs a bit to go to the sedation centers to get treatment. However, when folks go to the ER and they're only getting antibiotics and pain medication, that also costs the state. So we have to kind of give them the return on investment, if you will, to increase those sedation room costs and things like that. So Jeanette, I'm not quite sure where we are with the Department of Analytics. Would we be able to have some data for this letter sooner than later, or could it be an addendum that's added to the letter?
That's a good question. I'll follow up with that, and we'll see where we are. I know that you were working with Cindy on that, so maybe I'll reach out to Cindy as well. But it would be great to include that in this letter. Absolutely.
And if it turns out that we get a general letter written and then we have an addendum later on when that data is available, we can do that. But I think that's a strong message for the legislature. You can spend money here and now and to treat disease, help ease pain and suffering, or you're just spending your dollars over here and they're not really doing anything. These kids still have dental disease, they're still not getting treatment, and it becomes a very inefficient system, right?
Agreed. Yeah, and I think those statistics would go a long way. So, I think moving forward, as long as we get those bullet points of the history that you'd asked for through Dr. Wickers, Dr. Wickers, you have your hand up.
Yes, it's also Gina Hernandez here. Just wanted to try to get an estimate of time, because right now the budget is being made. So we have been talking about this for the last couple of meetings. So I don't know if this letter will actually help us. If the budget is already made, it could be a little too late.
Yeah, and this is one of those things where it's not like, for us as an advisory board, we want to make sure that we have all of the information. This can't be a unilateral thing where we just say, oh, we're going to support one thing. We want to make sure that the system itself for the state of Nevada is right. And you are absolutely correct in everything you're saying. So I mean, we can get the letter out, but it's going to have to be, approved at the next meeting. So with that, I don't know if that's going to be enough time. However, well, like what Dr. Rosenberg said, some of these things should be able to happen without the legislature. So, giving this letter is certainly with, because in the past we've had certain state senators who have been involved with this. So I think it still is going to be a passionate plea for us and for the underserved population in Nevada, but we still have to go through the procedure and have it approved next time. So that's all we can really do.
Well, thank you so much.
Julie, you have your hand raised.
Yeah, I just wanted to add a little bit more context and maybe clarification around the state budgeting process. It is true we are in the middle of budget build at the agency level. However, the final governor's recommended budget isn't really made public until he gives the State of the State address prior to the beginning of the next legislative session. So if you're concerned about timeline, it takes a while. And I think you guys are right in line with being able to get something drafted, have it approved appropriately at your next meeting, and still be in the time frame for it to be considered during budget build.
Wonderful. Thank
Thank you for
Julie,
that information, Julie. That's great.
So I think, Jeanette, for the end of this would just be to have those bullet points from Dr. Rosenberg and Dr. Wickers, making sure that we can maybe look through some of the archives as far as to see if there was anything public about the alignment of Medicare and Medicaid in the past, and then we'll start drafting that. And then if we get the data from ERs, hospitals, and some of the data that we would need to as an addendum for that letter, I think that would be beneficial as well.
Okay, so we'll have that letter ready for the next AC4OH meeting for approval, which is in May. Okay. And then who will be the lead on that letter?
So we'd had a work group established with Dr. Collier and myself.
That's right. Thank you. Okay, thanks. Let me know if you need me to schedule that work group in between.
Okay, thank you.
Great. Is there anything else on this agenda item? Okay, so moving on to we have the standing item number 14 about actions needed to fund the Nevada Oral Health Program. I think I let you know at last meeting that we were notified that the oral health program funding from the Healthy Nevada funds will be discontinued June 2025. So we have one more fiscal year. And just some background, this funding provides salary for the state public health dental hygienist, and then some funding for the oral health program overall. So we've used the funding for the third grade basic screening survey that we haven't had since 2008. And then some supplies and resources for when we do outreach events and some travel to attend those events. It's not a big budget. I think the total for 2 years is about $160,000. So we were told that they cut the budget and that they will be using those funds to provide services. I'm not sure what that means. So we're looking for alternate sources of funding. So we're really, going to be looking for grants, trying to get as many grants as we can. And then Dr. Benson has been working hard at getting funding for the state hygienist position to be under Medicaid with him. And then we also have the ARPA sealant program funding, where we were able to ask for half of the oral health programs coordinator's salary to help provide sealants in the counties where those children are not receiving programs right now. So we do have some options, but it is unfortunate that that sustainable funding that we had, and I think UNLV worked pretty hard to get that funding originally, that we will no longer have it. So that is where we are there. Yes, Terry?
So what happens if you get this HRSA grant that you just applied for? Is it a 5-year grant?
So the one we applied for is a 4-year grant, yes.
Was there money in there to support the oral health program?
We did include some salaries for different positions to keep it going if that ends up being the case.
I mean, I'll speak for myself as an AC4OH member, and I've been here for a long time. It is a tragedy if we lose the staffing for the oral health program. I mean, we can't afford that. I'm on pins and needles waiting for the BSS to come out because it's been so long and we need some current data, and I'm tired of citing 2008, 2009 data. So what can we do?
I wish Dr. Benson was on the call. It's as an advisory committee, I mean, we give our reports once a year, right? To the director. So I don't know if we could do a report of, here's what we've accomplished without this funding. this is how the AC4OH is run as well. I mean, I will keep doing the roles of the AC4OH because I know how to do it. But once this position is gone, it's kind of hard. And that's another thing is the AC4OH lives at DPBH, and with the SB44, it's in the director's office. So we have that aspect of it as well.
Yeah, because I don't even think we as a committee can meet without having someone from the state to facilitate, host the open meeting laws, post the agendas. Like we
Dr.
can't.
Benson might have to do it. And I know he doesn't want to, so he'll find funding.
Does he know that?
You're right. Yeah, there's a lot that goes into it. And really, I mean, the funding is, like I said, for the BSS, I mean, I don't know how, unless we get more grants, that we will continue doing, you know, those surveys that we need to be doing. Oh, Lynn has her hand up.
I do. I'm saying this as a member of the AC4OH and not as a contractor with the state of Nevada. The dental association, a person who was on previously, asked if there were any things that we thought she could be moving forward. I think that it's incredibly important. I think that they hold a lobby day. They have constant communication with the legislators. Every one of their members goes to the dentist on their own or has dental professionals working in their office that could voice an opinion or send a letter, including the Dental Hygiene Association as well, in order to provide support for this particular office in providing data and moving Medicaid and all of the different things that the office does, and including all of those collaborations, Jeanette, that you've been developing with the MCH Coalition, you know, cancer coalitions. All of those people need to really value and understand oral health, and their voices need to be heard. And I think that one of the things that the Dental Society or the Dental Association can do is to be very vocal about their expectation of an office of oral health and oral health being represented at the state level. And the more voices that are heard, then I think the more the importance of it is. It can't just come from us sitting here. It needs to come from outside there, and that's something that they can do.
That's a great point. And I will follow up with Jody.
Just to follow up on that, would it be helpful, Jeanette and Lynn, if we formatted like a base letter about the oral health program and then a budget, just a very basic budget of expenses and overhead and salaries, so that we can give it to these partners and say, hey, could you help support the oral health program? And here's some language, because we talk about how important it is, but I don't think, they may not be aware of how inexpensive it is, B, what you do, and C, how it benefits the state. So maybe we need to put that into some sort of an easy synopsis that other folks can carry the water.
That's a great idea.
Do you want to assign a work group, Dr. Bryant?
Dr. Bryant,
Sorry,
are you on? Oh, there you go.
Do I have anyone who wants to volunteer for the work group?
So Lynn, if you help me, I'll work with you on it.
I'm happy to provide some input through my personal email, Terry. I just don't want to cross a line and then cause more problems being a contractor with the state in doing that. But I'm happy to provide any sort of input or anything like that. I mean, I would hope that perhaps maybe Jeanette can contact the Dental Hygiene Association person who isn't on the line. I don't want to be one to nominate someone who isn't on the call, but maybe even the Dental Society person could be on the call. And again, I say this, every legislator has a dentist. Yeah. That dentist should be reaching out and talking about oral health during those visits. And I don't know how or what that mechanism of communication is. It's sort of like talking about water fluoridation, right? You have them in the chair, you talk about all of those things are important when they're important, not just during the legislative session. So, right. That's an important aspect to remember.
I think more than anything, what we need to do is get maybe 3 of us committed to drafting a basic letter with Jeanette's assistance. And
Someone
had a little-
volunteered. Who was that?
Yay! Rodrigo? Did you see that, Jeanette?
I do. I'm sorry. I'm not familiar with Rodrigo, so.
I know I am really bad at Teams, but I saw someone volunteer.
I thank you. After March 2024 is fine. I think that's plenty of time.
I'm just trying to help you so that we have something
No,
and
I
a
appreciate
one-pager. And then I can definitely help you with the budget. I think I have an idea of what would look good for a budget, and I can get some help through Future Smiles to make something that's a one-pager that people will easily understand. And then I saw Dr. Van Orton. Would you want to help us as well as a AC4OH member? I don't know if we could do a work group of non-AC4OH members.
I can assist if you would like. Yes, I'll do my best.
Okay.
So I'm on several committees.
Just having another set of eyes. So it looks like Enrico is a assistant professor at the dental school, if I got that really quickly. Yeah. Can we have a non-AC4OH party help us with something like this as a work group? Does anyone know?
Well, it's a public meeting, so they would just be there for public input, and then just run it as we do these meetings.
Okay, well then, do we need a motion for the work group? Okay, Dr. Bryant, there you go.
Awesome. Okay, so I would like to motion for this work group. I need to repeat all the names.
I can help.
Miss
So
Terry, Miss Tara,
Lynn
and
Short.
Lynn, I was gonna say, Lynn, are you officially in there or unofficially in there?
I think I'm unofficially in there, but I'm yeah. And we'll just use my personal email.
And then Ronrico from UNLV. And then I will second the motion to establish an ad hoc committee or a work group, excuse me, for support documentation for the oral health program moving forward after 2025.
You know, Jeanette, it might be useful to like pull together some successes. You know, and that way they can be listed or bulleted, or maybe, you know, we can make some sort of an infographic or something that, you know, would draw the attention to the successes that have happened since the funding has started over the last couple of years.
Great, thank you. And I'll ask Jennifer Bradley as well, because she's our PR person on the committee. So she might be a good person to kind of highlight this in a nice way. So do we need to vote? We had a second, but we have to vote, correct?
And just before
the committee has to vote. Oh, sorry.
Just before you vote, because a work group can be done offline with 2 members, but if more than 2 members is involved, then we would have to post the meeting. You would have to have open meeting laws. So I just wanted to point that out just to make sure that we're that Jeanette or someone would have to be a part of that to set up meetings and offer it to the public if it's more than 2 people.
That's kind of what I was wondering about. So should we just have Dr. Van Orton and I, and then any other public person like Ronrico, who's having his microphone's not working, we can have them participate and go that route?
I think that's a good idea.
Okay, so then I amend my second motion. Now we can vote.
Great, thank you.
So all in favor of the work group of Dr. Tara Van Orden and Terry Chandler, do I have a raise of hands?
Aye.
Aye.
Aye. Aye. All right. I think we're good. Moving on. Sorry, let me pull up my. Okay. Okay. Does that bring us to
15?
Okay, so we well, yeah, we just concluded 14. So public comment. Action may
Oh,
not
no.
be taken.
I'm sorry. Hold on, Dr. Bryant. 15, discussion of recommendations for future agenda items.
That's 14. Am I looking at the right one? Okay, so discussion of future agenda items. Anyone want to make a discussion for any future agenda items? No? Okay, so back on to another number 15. Public comment. Action may not be taken on any matter brought up under this agenda item until scheduled for an agenda for a later meeting. Public testimony under this agenda item may be online, by phone, or written comment. Due to time considerations, each individual offering public comment will be limited to no more than 3 minutes. Anyone have a public comment? No. Oh, one person raised their hand. Jeanette, can you assist me and figure out who it was?
Yep, Jessica Woods.
Yeah, my question was just, I know that the committee had drafted and approved a letter that was sent to the dental board. I was just wondering if there was any updates on that being submitted, or if we've received any response or anything like that.
Yeah, I haven't received any response. I will follow up with Dr. Collier. I know she sent it. I'll see if she received any response, but I haven't heard of anything. And I don't believe Dr. Benson has either. So
who did we specifically try to contact on the board? Did we just say to the board? Who did we try to use as our point of contact on that?
I will have to ask Dr. Collier who it was addressed to. Let me ask her.
Because I could probably contact someone who knows someone who could directly contact that person.
Okay, great. I'll find out and I'll let you know. And I'll let you know, Jessica, as well.
Wonderful.
Thank you.
Okay. Anyone else for public comment? All right, so let's go ahead and we're going to adjourn this meeting. I am Dr. Bryant, and thank you guys for a great meeting. I really love the presentation, and I feel like this committee always does such great things.
Do we have to someone make a motion to adjourn the meeting?
I'll make a motion to adjourn.
This is Tara Van Orden. I'll second.
Okay, all in favor, say aye.
Hi.
Aye.
Aye. Okay, great.
Thank you, everybody. Have a great day.
Thank you all. Have a great weekend.
Thank you.